Okay, today I'm going to be focusing the presentation by talking about my K23 award in Mozambique, which aims to treat common mental disorders in women by addressing intimate partner violence in couples. I have no disclosures or conflicts of interest. The objectives of the presentation are to, one, understand the importance of addressing intimate partner violence, or IPV. Two, learn about interpersonal psychotherapy for couples. I hope Myrna Weissman is watching online. She couldn't make it in person. Or IPT. So I'll be using those two acronyms frequently throughout the presentation. IPV for violence, IPT for therapy or treatment. And then third, identify implementation considerations for IPT for couples in Mozambique. So just a few slides about the background. First, I think a lot of people know, and I'm probably preaching to the choir when I say that intimate partner violence is a significant public health problem. It affects 1 in 3 women globally. This is a figure that was published in The Lancet in 2022 that shows that there's national and regional variance as well. The lower prevalence is shown in the blues and greens, middle levels are yellows, and higher prevalence is in the dark orange and red. As Adi mentioned in my bio, I've been working with gender-based violence in sub-Saharan Africa for many years now, where some of the highest rates of IPV persist. There are a lot of negative impacts of IPV if we think about this as a public health problem. The first are physical in terms of injuries, also reproductive health concerns. There are psychological outcomes such as depression, anxiety, and PTSD, and also suicidality. There's socioeconomic implications, and there's an intergenerational effect such that children who witness IPV grow up later to become victims and perpetrators of IPV and have significant mental health problems and substance use issues as a result. So given all of this, the World Health Organization has recommended addressing IPV as part of mental health services. And Sai and colleagues did an interesting analysis that showed that addressing IPV has effects comparable to those of short-term psychotherapy treatment for depression. I also want to talk just a little bit about why couples therapy for IPV, especially for the practitioners in here, because the standard of practice is typically to separate couples who have IPV. And there was supposed to be a figure there, and I don't know where it went, but is there? Oh, it went back? Okay, it's there. Well, I'll just describe. This is from research that we found conducted in Uganda. So we looked at why place and space matter for IPV survivors' mental well-being. And what we found was that the family unit, there were a lot of sociocultural and also infrastructural considerations that kept that family unit together, and family harmony was highly valued. So maybe to separate the couple and work with them individually, like is done in the US and the West, might not fit the paradigm. But the question has become for me in the K23 award, what will work to work with the couple and reduce violence? We know that working with couples for IPV is effective. At least one meta-analysis has shown that working with couples is more effective than treating individuals, which makes sense if you're trying to resolve IPV. And this is with the caveat that we have to be careful about the typology of IPV. So situational IPV is mild or moderate violence that escalates out of couple conflict, and this tends to be more bidirectional. And this should be differentiated from severe violence or intimate terrorism. So this is use of a weapon, control, stalking, things like that. These would not be good candidates for a couples therapy. The second background piece of information I'd like to talk about is why interpersonal psychotherapy for couples. I have Myrna Weissman featured here because she's an advisor and also co-developer of IPT. So we didn't choose this just because she was my boss and chair at the time, but there's a conceptual reason as well. So one, IPT focuses on 4 interpersonal problem areas and resolving those. One of those areas is dispute. Move forward, okay. And IPV, the idea of this treatment is to resolve IPV as a form of dispute, improve the quality of the marital relationship, decrease interpersonal stress, enhance social support, and ultimately reduce symptoms of depression, anxiety, and PTSD. Another very important reason is that a brief version of IPT called interpersonal counseling is being scaled up across Mozambique to treat common mental disorders. This is through the work of my primary mentor, Milton Wainberg, who's here with us today, and his Pride project led by him and Mariah L in collaboration with the Mozambique Ministry of Health. And we found that through the certification of a national cadre of trainers and supervisors in Mozambique, they saw 160 patients. Over half of those identified dispute as their main interpersonal problem area, and 64% of those identified the dispute as being with an intimate partner. But IPT is not sufficient on its own, given the special safety and ethical considerations for working with IPV. So we've added some safety features and an IPV module. And this is from the work of Sandra Stith, who's another mentor and advisor on MyK. And this is her evidence-based therapy that she developed here in the United States. So this brings us to the K23 award, and I'll talk a little bit about the aims and what we found preliminarily in some of those aims. And I have Dr. Palmira Fortunato dos Santos, who's kind of my main colleague and collaborator in Mozambique. She's also an expert in Mozambique mental health system, and we work very closely together. Just a note about context. The K23 is situated in Nampula City, which is located in Nampula Province, featured in the red here. And it's an urban setting. It's the third largest city in Mozambique. It's very diverse. The largest local ethnic group are the Imakua, but there's also a lot of Lebanese, Indian, European, and Chinese people who live there. So if you like good food, I would recommend a visit with us. It's considered to be matrilineal, which is important for working with couples. That just means that women remain associated with their kinship network following marriage, and they retain rights to their children. And in terms of mental health infrastructure, it's the site of one of two psychiatric hospitals in the country. The other is in Maputo, which is in the south, close to the border of South Africa. This is an overview of the research aims and timeline. The first aim, we knew that the biggest barrier to this therapy and its feasibility was about engaging men. So the first aim is formative work to identify gender roles, including local contextual influences relevant to engaging men in this couple-based treatment. Then, secondly, to adapt the therapy for Mozambique from an individual modality to couples, to incorporate the safety features, etc. And then finally, to determine acceptability and feasibility. Regarding the first aim to identify gender roles, we conducted 11 focus group discussions and 8 individual interviews with 85 participants with a range of stakeholders, men and women from the community leaders, people who had expertise in gender-based violence and mental health policy, and also work on the ground. And because this is an implementation study and the main outcomes are implementation ones, I've, of course, used implementation framework, and this is a framework we've used in previous work in Mozambique. It's the consolidated framework for implementation research, and I'm not going to go into it. There's a lot you could probably say about it, but there are 5 main domains which are featured here. But we found that one of the gaps was that they didn't look at gender roles specifically. So we took a gender roles lens and applied it throughout with the interview guides, the focus group guides, and also through analysis. And I'll show an example of how we did that on the next slide. The first analysis we did was about engaging men. And the main mentor of this work was Dr. John Olive, who's an expert in engaging men in mental health and healthcare. And we applied a masculinities lens to better understand barriers and facilitators to care for men and how we could, or community level recommendations for how we could better engage them. So some of the main barriers were around vulnerability. So although this is a matrilineal culture, we found that people talked a lot about these traditional masculine sociocultural norms around especially expressing vulnerability and that being a form of weakness around the quote unquote soft emotions like sadness and fear, and not wanting to express those, and that would be embarrassing for them. The second thing people talked about was this dynamic between the provider and the patient, where the provider has power, the knowledge, advice, and they're conferring that to the patient. And that sort of put men down in this power hierarchy, and that they might be less interested in entering into that kind of dynamic. But despite many barriers, people also recognized that there were some facilitators to care. First, that men are very diverse, and they talked about the difference between urban and rural populations, and that some men might be more likely to engage in this treatment. And across the board, people had high acceptability for this intervention. So people tend to understand the value of engaging men. In addition to that analysis, we also looked at barriers and facilitators across the domains of the consolidated framework for implementation research broadly. We've looked at special implementation considerations for people living with HIV, because we know IPV escalates during this time, especially for couples who are discordant, where one is positive and the other negative. And we've also looked at implementation considerations for pregnancy and implementation of this kind of treatment in perinatal care. So taking all of that information from the first aim, we then adapted IPT for couples. We did initial adaptation with the experts, mentors in our team. We held some adaptation work groups in Mozambique. The first one was the national trainers of this brief version of IPT. I can hear a Zoom maybe coming through. The community partner technical team, also for community input. So that's experts in gender-based violence and mental health in Nampula City. So we got their feedback on the manual. And we did a 3-day work group with psychologists where they did the activities and practiced those. And I see a sign in to iMessage that showed up here. Oh, ignore it. Okay. Not relevant to the presentation. So one of the, as I mentioned, with some of those barriers with engaging men, we felt it very important to frame this in a strength-based way. So the intervention is called Healthy Family, Happy Family. But, and uh-oh, ID just left. I have another something saying don't install and relaunch. Hopefully it'll just go away. The last time I was in Mozambique, I heard a nice jingle on the TV and heard the song about Feliz Familia. So we learned that it's a popular brand of rice. And the family did look very happy because they were eating this rice. So we're rebranding now. We're in the process of working with a local designer and also community leaders and elders about how we can frame this, especially thinking about how best to engage men and capitalize on those values of family harmony and having a strong family. This is the general structure of the intervention, and we have pages and pages of adaptations. If anyone's interested in those, I can't present them now, but please feel free to reach out to me. But essentially, we've included a pre-treatment session with men and women individually, where we use motivational interviewing, a therapy that reduces the power hierarchy to work especially with engaging men, women too, but especially men. We look at the problem areas, interpersonal problem areas for both members of the couple. We felt initially that while women's mental health were the main outcomes as proposed in the grant, that we sort of needed to make it more about the couple and really working about strengthening the couple. And that included men's mental health and their background. So they didn't get this message through therapy that they're the bad ones or something's wrong with them. We wanted to be very careful about that messaging. And then you see sessions 1 to 8, we do some wraparound safety assessments individually before and after the session, just to check in if anything had happened across the week that people wanted to bring up in an individual manner, or if something comes up in the therapy session, there's a quick check-in just to see about people's anger levels or how safe they might feel. The next step, which we're very excited about and eager to start, is to do a pilot randomized control trial with 50 couples attending 2 outpatient mental health clinics in Nampula City at the psychiatric hospital and also a generalized central hospital there that has outpatient mental health services. Our primary outcomes, as I mentioned, are implementation ones, acceptability and feasibility, and then we also look at effects of common mental disorders in IPV victimization and perpetration among women, men individually, and then couple functioning together. So I'd like to thank my mentors and advisors on the left-hand side, and also the local team in Mozambique featured on the right. And thank you all for being here in person today. Thank you.
Thanks, everyone. We're going to hold off on questions till the end when we'll invite all three of the speakers to come to the stage and share questions.
Sorry, to show you how important all of our indirect funding is, the person funded by indirects is currently away, and that is why we're having so much difficulty right now. But we are getting there shortly.
Thanks again. By the way, for those of you who haven't noticed, and this is perhaps a testament to Jennifer, we have the most well-behaved baby in humanity in the auditorium today. Has not made one sound. Obviously really enjoyed your talk. Next up is Dr. Morgan Firestein. Dr. Firestein is an associate research scientist in the Division of Developmental Neuroscience here at Columbia. In collaboration with the Departments of Pediatrics and OBGYN, she applies a psychobiological approach to identify and examine prenatal risk factors for autism and related neurodevelopmental disorders, with the overarching goal of facilitating early diagnosis and intervention. Dr. Firestein received her PhD in 2019 from the Department of Psychology, also at Columbia University, under the mentorship of Dr. Francis Champagne. As a graduate student, she received an NSF Graduate Research Fellowship, and more recently, a T32 training fellowship, and now a K99 R00 award through NICHD. As you can see, a theme with all of our speakers today is how vital early training opportunities are in making a research career. Her research has been disseminated in several journals, and she's had papers in JAMA Psychiatry, JAMA Pediatrics, and she also serves as the director of the Perinatal Biobank, which is a joint effort between pediatrics, OBGYN, and psychiatry. Her mentor currently is Dr. Bill Pfeiffer, who is also with us today. So without further ado, Morgan.
Great. Well, thank you all so much for being here today. Can you hear me okay? Great. Thank you so much to the Grand Rounds Committee for including me in today's program. My hope is that by the end of my presentation, most of you will agree that the importance of the prenatal experience and the placenta even really does not end at birth, but rather it continues to inform much of the work that we do here in our department. I have no disclosures. The learning objectives for my presentation include an introduction to a proposed fetal ecological systems model, a discussion around associations between prenatal maternal hormones and child neurodevelopment, and finally, consideration of some early findings on extracellular vesicles and child neurodevelopmental outcomes. Now, in light of the latest developments affecting our department and institution, I decided actually to move this slide towards the beginning of my presentation, really to emphasize that all of the work that I'm about to share with you has truly only been possible because of my incredibly supportive team of mentors and collaborators, many of whom are part of this department, because of the support that I've been fortunate to receive through both private and federal sponsors, including the NSF, the CDC, the NIH, as Adi mentioned, through a T32 and now a K99. And of course, all of the families who have given their own time to join us as a scientific community, really to try to help us move our own science forward. And so, of course, I really hope that these resources all continue to be available to early career scientists that come after me. So I'm going to start with a statement that probably many of us in this room agree with, which is that genes interact with the environment to shape the brain. And this is what I'm showing you now. This is Bronfenbrenner's ecological systems model from the 1970s, where he proposed a framework where the individual is at the center and there are these spheres or layers to the environment that have the ability to affect that individual both directly, indirectly, and in an interactive effect with one another. But I would argue today that there is even an earlier environment that is just as complex, certainly just as critical, and that is the environment of the fetus. And so what I just want to quickly walk through today is my proposed fetal ecological systems model. So in this model, we have the fetus at the center, and it can be influenced by various spheres in the intrauterine environment. This would include the amniotic fluid, the placenta, that really serves as the primary interface between mother and fetus throughout the pregnancy. The maternal and the mother's system, this would include her own physiology, hormones, psychological states and mood, health conditions, thinking about diabetes, various health conditions during pregnancy, and diet and nutrition. And then going out even further, we can start to think about the maternal environment. There's actually a very rich literature now supporting this notion that cues from the maternal environment actually can be translated to the fetus through placental regulation. And finally, really critical that we contextualize all of these different aspects of the environment across gestational age, recognizing that it's very likely that, for example, one of these factors might have a more profound effect on the fetus at the first trimester compared to the third trimester, for example. So through my research, I have tried to apply this framework to the field of autism research to try to more comprehensively evaluate various prenatal risk factors and early indicators of autism risk. So I think many of us are aware that prevalence has been increasing steadily over the last few decades. And we don't have a clear understanding of exactly why this is occurring. Certainly, part of it is due to diagnostic changes, but that's not the entire explanation. But one thing that we do know is that early intervention is a critical tool for improving outcomes and quality of life. And because of this, there's really this urgency to develop early emerging biomarkers of autism risk so that we can identify those children who really stand to benefit the most from early intervention as early as possible, with the ultimate goal of trying to improve outcomes. Now, when we think of possible early emerging markers, there are a few considerations that I just briefly want to introduce. The first is that we know that there is a genetic component to autism. So this is just a summary of many, many studies where they have compared the concordance rate between siblings, dizygotic twins, and monozygotic twins, so genetically identical twins. And what you can appreciate is that dizygotic non-identical twins are more likely to have a concordance of their diagnosis, so both will be diagnosed with autism compared to non-twin siblings. And then monozygotic identical twins are much more likely to both be diagnosed with autism. But it's not 100%. So there are situations where there are genetically identical twins in which both are not diagnosed with autism. And so because of this gap, there's also this idea that genetic contributions are likely interacting with the intrauterine environment to confer risk. In terms of thinking about different exposures and the role of the placenta in regulating exposures, there are two types of exposures that we sort of commonly think about. The first would be exogenous exposures. So this would be exposure to environmental toxicants, medications, and drugs, for example. I'm not going to speak about that today. Mariah, fortunately, is going to be talking about exactly that next. But rather, I'll be focusing on endogenous exposures, in particular hormones and extracellular vesicles during pregnancy. So this is work from another group at Cambridge University, Simon Baron-Cohen's group, where he has been able to measure amniotic fluid levels of testosterone during pregnancy, mostly in the late first trimester. And what they have found is a positive association between higher levels of testosterone in amniotic fluid and more autism-related behaviors. This is the Q-chat, very similar to the M-chat for those who may be familiar with that autism screener. Not clinical, really just looking at total number of behaviors that have been associated with autism. And what I really want to point out here is that they label this fetal testosterone, meaning of fetal origin. And the reason that it has been understood to be of fetal origin is because as testosterone reaches the placenta, it interacts with an enzyme called aromatase. And aromatase is responsible for converting testosterone into estradiol. But the idea that there is this placental barrier against maternal testosterone also assumes that the permeability of that aromatase barrier is consistent across individuals. However, more recently, what we've come to understand is that aromatase and its transcriptional regulator Aurora, so here's aromatase and Aurora, both are actually underexpressed in the prefrontal cortex of children who have been diagnosed with autism compared to neurotypical controls. And what I haven't mentioned yet is that the placenta and the fetus are genetically identical to one another. The placenta really belongs to the baby, not to the mother. And so it's biologically possible then that in an individual where brain aromatase is downregulated, underexpressed, it may also be underexpressed in the placenta, and thus would allow more maternal testosterone to actually cross that placental barrier and enter the fetal circulation. So to test this hypothesis, I was able to partner with the New Mom to Be study. This is a wonderful multi-site study that enrolled about 10,000 pregnancies across the country. 661 delivered right here at Columbia and met all of our eligibility criteria to participate in this ancillary study. This meant that they had the necessary biospecimens, including maternal plasma, from which we could measure testosterone and estradiol in the second trimester. Cord blood samples collected at birth, similarly to measure testosterone and estradiol from the fetus, and placenta, through which we could extract RNA and actually quantify the expression level of aromatase in the placenta. And what was so wonderful about this study was that by the time I had joined this team, the children were actually already between 4.5 and 6 years of age. So it really functioned already as a longitudinal study, and I was able to have the parents complete a parent report measure of child development. So certainly want to acknowledge the limitations and caveats of that. And I'll focus right now on the social communication questionnaire, which is, again, an early autism screener, not diagnostic in any way. So what we found, what you're seeing here in white are the children whose mothers had low levels of testosterone during pregnancy. And in blue are those where the mothers had higher levels of testosterone during pregnancy. And in females, there really was not a difference at all. But in males, which is very interesting that it was a sex-dependent effect, you can see that the children whose mothers had high levels of testosterone in the second trimester had higher scores on this social communication questionnaire, where more scores indicate more autism-related behaviors and traits. And then we wanted to also contextualize this thinking about aromatase. So we were able to categorize each child into one of 4 groups based on the level of maternal testosterone in the second trimester and the level of placental aromatase expression at birth. And what you can see here is that this last group over here, where there was high maternal testosterone and a lower expression profile of placental aromatase, which was our hypothesized highest risk group, did have significantly higher scores on this measure. But I do also want to point out that there is a lot of variability here. This was a community sample, a convenience sample, not in any way enriched for autism or neurodevelopmental disorders. So we did actually have some children who had been diagnosed with autism at the time of this assessment, but certainly a lot of this variability probably stems from the fact that this was not a clinical sample. So having explored these endocrine factors, I later pursued a postdoctoral fellowship here in the Department of Psychiatry with Dr. Bill Pfeiffer as my primary mentor. And I began that in January 2020. And I really wanted to sort of shift gears, but stay with the general theme of placental regulation of fetal exposures to endogenous factors. And so I really wanted to focus on these extracellular vesicles. And I'll talk more in a moment about exactly what those are and what we think they do. I was very fortunate to very quickly receive some early pilot funding that allowed me to collect some early data on this. And ultimately, this resulted in a K99, which I am currently in the second year of. My K99 has been co-mentored by, as I said, Dr. Bill Pfeiffer in the Department of Psychiatry and Dr. Anna Penn in pediatrics. She's the chief of the NICU and has really pioneered this exciting new field called neuroplacentology, how the placenta shapes the brain and influences behavior, and maybe vice versa as well. But I was really focused on prenatal extracellular vesicles and bringing in steroid hormones, both as biological mechanisms that might underlie known gestational factors that are associated with neurodevelopmental risk. So what are these extracellular vesicles? They are a membrane-bound lipid bilayer structures that are released really from nearly all of our mammalian cells. They contain cargo material, including RNAs, DNAs, proteins that are representative of the cell of origin. And very much like hormones, they are released into the bloodstream, carried to distant cells, and these recipient cells can actually experience phenotypic changes as a result of these EVs being taken up by those cells. And there is emerging evidence to suggest that these EVs are playing a role in many different neuropsychiatric conditions. So, for example, what I'm showing here, this is a study where they looked at specific microRNAs in extracellular vesicles that were differentially expressed in patients diagnosed with depression versus bipolar disorder, schizophrenia, and there's some interesting overlap between these as well. And then in children, this was a study of 4 to 12-year-old children, some of whom had been diagnosed with autism compared to here healthy controls. And they were actually just looking at the total protein level if they extracted those vesicles, sort of as a proxy for, we think, how many vesicles there may be in the sample. And you can see that the children in the autism group had significantly higher total protein levels. So this is where I was at the beginning of my postdoc, understanding this link between maternal androgens and autism risk in offspring. And now we've been pursuing this question of, are elevated extracellular vesicles, or EVs, also associated with offspring neurodevelopment? So I was very fortunate to be able to go back to this wonderful New Mom to Be study. We could, from the same exact samples, extract out these extracellular vesicles. And first, we can, just like that other paper, looking at total protein levels, we can look at those levels in the EVs. We can also examine the composition of these vesicles, so looking at them based on density by size. Looking at specific EV markers, these are tetraspanins that are proteins that are specific to vesicles. And then we are about to be actually sequencing the cargo material to see whether there are specific microRNAs that might be differentially expressed in maternal samples and cord blood samples of children who are later diagnosed with autism or showing some early indicators of autism-related behaviors. So just really briefly, we categorized all the children into one of two groups based on their scores on a number of assessments. I've already talked to you about the social communication questionnaire, so using a predetermined threshold there. We also conducted the BASC-3, focusing on 3 domains of hyperactivity, developmental social disorder related behaviors, and overall clinical probability. And if a child met the threshold on any one of these, we categorized them as being high risk. There were 60 of these children, and we matched them to 60 low risk children who did not meet criteria on any of these 4. And we matched them based on gestational age at birth, age at assessment, and the child's sex. So this is just really early preliminary data. But what we're seeing so far, really interestingly, is that the children in the high-risk group at birth in cord blood overall have lower total EV-associated protein levels. We're not seeing a particularly robust signal in the maternal samples, but we also see a really interesting signal when we look at the maternal to cord ratio. So these are instances where there are high levels of total EV-associated protein in the maternal samples and low levels in the cord blood. This ratio is much higher in our high-risk children. And just to focus on the maternal, where again, we're not seeing a main effect here of total protein level. Some of our early analyses as well, looking at the actual composition of these vesicles, we are seeing that in the maternal samples, there is a much greater density and concentration of the smallest vesicles, these exosomes, which are widely studied in the literature because they most readily cross the blood-brain barrier and the placental barrier. So hard to interpret too much, but definitely intriguing. And again, our next steps will be to actually look at these specific protein markers and sequence the cargo material. Just very briefly, for the R00 phase of my grant, I'm planning to prospectively enroll a cohort of women who have been diagnosed with a maternal metabolic condition during pregnancy, focusing on hypertension and gestational diabetes. Both of these conditions have been associated independently with both elevated extracellular vesicles and altered microRNA cargo material in those vesicles. And finally, there are actually protocols now that allow us to pull down vesicles that originate not just from the fetus, but actually from fetal brain cells. So a lot of exciting next steps. And I'll just leave you with this, which is, again, going back to this ecological systems model, many levels here, but most importantly is that they are not independent of one another. There are probably a lot of interactions happening here. And so trying to take even more of an exposome level approach moving forward. So thank you so much for this opportunity and for your attention.
Thank you, Morgan. Last but not the least, we have Dr. Mariah DeSerisy. Dr. DeSerisy completed her PhD in clinical psychology at Fordham University in 2021. In her graduate school, she focused on understanding behavioral, cognitive, and neurobiological risk and resilience for emotional dysregulation, including irritability and anxiety in kids and adolescents. Clinically, she specializes in providing evidence-based treatments for children and families struggling with severe emotional dysregulation, trauma, and high-risk behaviors related to suicidality, substance use, and self-injury. Her current research interests include the neural etiology and impact of environmental and social exposures on risk for childhood psychopathology. As with the other two speakers, she is a T32 trainee and was awarded a K23 by the NIMH, called Air Pollution Effects on Child Irritability and Brain Connectivity. Her advisor and mentor, Amy Margolis, is also here with us tonight. So without further ado, Mariah.
All right, thank you so much for that kind introduction and for including me today. Can everybody hear me? All right. As has been alluded to so kindly by Morgan, I am going to be speaking today about the exogenous environmental influences on brain function and children's mental health outcomes. I have no disclosures to make. The learning objectives for today's talk, as well as my outline, include to define irritability in childhood, identify some environmental risk markers for that childhood irritability, and finally to describe my newly funded K award, which examines air pollution effects on irritability. So first, I'll define irritability. Irritability is common in early childhood, as most parents of toddlers can attest, except maybe that one, before children develop the skills that they need to regulate their behaviors and emotions. Typically, irritability in early childhood is characterized by temper tantrums, or short bursts of angry and aggressive behaviors interspersed between periods of relatively normal, neutral, or positive mood. However, irritability that persists after the age of 5 and into school age is a well-established risk factor for both anxiety and depressive disorders in adolescence and into adulthood. Persistent irritability, when it's clinically significant, is characterized by low frustration tolerance, angry, grumpy mood, and temper outbursts, which can be more extreme when you're 16 than when you're 3. Clinically significant temper outbursts typically occur in response to transitions or no responses from parents, and so might be thought of as having difficulty pushing pause, so having a hard time managing cognitive control in order to respond to big emotions. Much like a fever is a non-specific marker of psychiatric problem or physical illness, you can have a fever with a cold just as easily as you can have a fever with the flu. Irritability is a transdiagnostic marker of psychiatric problems and future psychiatric risk. But regardless of the diagnostic presentation, irritable symptoms are one of the most common reasons for referral to pediatric outpatient mental health clinics and are associated with considerable and functional impairment, including visits to the ER, problems at home and in school, and increased risk for abuse. So I've set out to identify some environmental risk markers for irritability. In my work, I'm trying to develop a biopsychosocial model of factors that contribute to childhood irritability. Right now, I'm focusing on risk with the goal of better understanding resilience in the future. My model has 3 interlocking parts that each drive different aspects of my research. The brain, the social environment, and setting my work apart, the focus of my first grant is on the chemical environment. However, in order to understand the effects of chemicals on the brain correlates of irritability, I first needed to understand what exactly the neural correlates of irritability in the first place were. Extant evidence indicated that neurobiological risk for irritability was concentrated in regions within networks that process emotion, reward, and threat. Disruptions in these circuits were associated with behaviors common among irritable youth, like difficulty perceiving when a good thing has happened to them, or difficulty in reward processing, and looking for a fight in an otherwise neutral situation, or difficulties in threat processing, or finding threat in places where it's not there. This is more commonly known currently as a hostile attribution bias. More recently, disruption in function of cognitive control circuitry, or the brain networks that govern information processing and self-regulation, have also been implicated in irritability. Behavioral manifestations of disruptions in these circuits are associated with the lack of a pause button, which, when working appropriately, should prevent you from reacting impulsively in an emotional situation, like yelling at your mom when she tells you it's time to turn off your video game and it gets started on homework. Importantly, nearly all of this prior work leveraged task-based designs, which requires kids to participate in threat, reward, or cognition tasks while inside an MRI scanner. Although this approach is good for targeting specific behaviors linked to brain function, participating in MRIs is hard, and in particular for little kids and those with irritability. Another way to examine brain behavior relationships is with resting state connectivity, and in particular, network-based connectivity, because brain systems don't function independently. We know they function together, and communication between those networks, or more specifically, network integration, is known to drive behavior. Related to irritability, I thought something might be impacting the communication, specifically between the cognitive control circuits, so those here, and the reward processing or threat processing networks separately, which would lead some kids to throw their game controllers and break the TV, but other kids to transition nicely and put the game away. There was some evidence for that in the clinical literature, given that irritable kids with good inhibitory control, so a good pause button, responded better to cognitive behavioral therapy than kids who had worse inhibitory control, which kind of makes sense in the context of cognitive behavioral therapy, because what we're teaching kids to do is replace a maladaptive behavior, in this case, a temper outburst or angry and aggressive behaviors, with a more adaptive one, a coping skill, the ability to take a deep breath and kind of walk away from a situation. So it would make sense that kids who can push pause, kids who are better able to access that deep breath and replace with a coping skill, are going to have a better response and better access to CBT. That led me to hypothesize that something is happening in the brain at the circuit level that changes how the cognitive control circuits communicate with these threat or reward processing circuits to prevent some irritable kids from effectively pushing pause in the face of those big emotions. On my postdoc, I tested that model through a registered report examining connectivity between these 2 network pairs and its association with irritability. Using 1,430 participants from the Healthy Brain Network open data set, we tested if connectivity between the cognitive control and threat or reward processing networks was associated with irritability in childhood. The Healthy Brain Network dataset is a psychiatrically weighted cohort of New York City children ages 5 to 21. We specifically used kids under the age of 18, in part because the sample above 18 is not very large, and particularly those with irritability measures. The sample as a whole is sociodemographically and diagnostically diverse, which means it includes children from a range of backgrounds and diagnostic presentations. In this sample, irritability was measured using the gold standard in the field at the time, the Affective Reactivity Index, or the ARI. The ARI provides one irritability score, which is created by summing these first 6 items, which you can see highlighted here in orange. That 7th item is really more a measure of functional impairment, and so it is not included in that total score. On these graphs, you can see that we didn't find exactly what we expected to in the entire sample. But when we dug into the data a little bit more deeply, we found, with connectivity being on the x-axis here and the parent-reported irritability scores residualized for a number of covariates on the y-axis on both sides, we found that specifically reduced connectivity or connectivity closer to zero between both network pairs was associated with irritability, but only in 5 to 9-year-old boys, not in girls or in other age groups, which suggests there's something going on developmentally or a sex-specific effect. Previous work indicates that positive connectivity between these two pairs of circuits is associated with better access to coping skills, like cognitive reappraisal, which means that our weak connectivity observed here could suggest that those kiddos don't have access to the same coping skills, which then results in lower emotion regulation and correspondingly higher irritability. During my postdoc, I also became curious about, as Morgan alluded to, the exogenous external environmental influences that might impact brain development. So I'll next discuss the influences of the chemical environment and my newly funded Career Development Award. Specifically, as again, Morgan alluded, neurotoxic chemicals are known to cross the placental barrier, which influences brain development in utero and results in a cascade of changes, both in the brain and in behavior across childhood. My K is funded by the National Institutes of Environmental Health Sciences and studies the effects of one class of air pollutant chemicals, specifically polycyclic aromatic hydrocarbons. And because that is a mouthful, I will be abbreviating it as PAHs going forward, on irritability symptoms and brain development. PAHs are a class of chemicals that occur naturally in carbon-rich substances like coal, wood, crude oil, tobacco, and gasoline, and are released when these substances are burned. Many of you will probably recognize the wildfire smoke from a couple summers ago. PAHs are also released when cooking at high temperatures results in charring. Regardless of where these PAHs come from, when they're released into the air, they can bind to and form small particles that are then inhaled, which can cross the blood-brain barrier and the placental barrier. In order to study the causal effects of chemicals, we turn to animal models. Frustrative non-reward is the animal analog of irritability. Frustrative non-reward involves teaching an animal, in this case a rat, to expect a reward and then unexpectedly not providing it. So here, this rat has learned that when the light turns on and it pushes the lever, it can receive a food pellet. But if the light turns on and the food pellet is not provided, we reliably expect that the rat will push harder and more frequently, so an increased task response akin to a child whining louder. And eventually, if that food pellet is still not provided after increased task response, increased whining from your 2-year-old, they are then known to become aggressive, which we say represents frustration. My mentor, Amy, spearheaded a review that back-translated human behavioral paradigms like frustrative non-reward to animal models in order to help identify and define the neural targets affected by air pollution exposure. This review uncovered causal evidence that air pollution exposure disrupts dopamine and dopamine-related brain circuitry to include reward, threat, and cognitive control pathways. Given that dopamine is very important for reward processing and cognitive control, which we just highlighted, it also plays a role in both frustrative non-reward and irritability in childhood, which indicated that prenatal air pollution exposure may actually cause disruptions in this dopamine brain circuitry that would then result in emotional instability, angry, and aggressive behaviors. For me, in conjunction with my work on the brain correlates of irritability, this paradigm highlighted a large gap in the literature. Although there was emerging evidence at the time linking PAHs to irritability and linking PAH and irritability separately to disruptions in dopaminergic brain systems, no work had yet examined an environmentally associated phenotype of irritability through brain circuitry, which led me to propose my K. My project is housed in the Columbia Center for Children's Environmental Health Fair Start Birth Cohort, which is a cohort of approximately 1,500 mother-child dyads. Recruitment for this cohort began in 2015 and remains ongoing. Mothers are recruited from prenatal care clinics in the New York Presbyterian Hospital System, with the majority living in Washington Heights in the South Bronx, which you can see here. The majority of mothers are Spanish speaking and without a college degree. I plan to recruit 100 dyads to participate in this work. First, I will examine PAH effects on irritability at age 4 or 5, defined using clinically and behavioral measures of irritability, including the RA, which I discussed earlier, as well as the disruptive behavior diagnostic observation schedule. For those of you familiar with the ADOS, this is built on the ADOS model and uses a series of presses to elicit atypical to typical behaviors in response to a frustrating experience. The preschool age psychiatric assessment is a clinical interview conducted with parents, again, examining a range of typical to atypical behaviors and capturing emotional, behavioral, and social experiences that many kids have happened to them during early childhood. The multidimensional assessment of preschool disruptive behavior temper loss scale, again, measures typical to atypical development because it's important that we capture a wide range of irritability, particularly at an age where it's common and normal in kids. The temper loss scale captures behaviors that happen during a temper outburst. These final two scales that are in front of you in italics are broadband measures of socio-emotional functioning and children's temperament, which will be leveraged from other studies. I will next measure approximately 18 months later persistent irritability by getting parent report of children's ongoing irritability symptoms using those same parent report measures. And finally, leveraging resting state data collected in another study, I will examine the neural connectivity between the control and reward circuitry as proposed in my K. But as we found in my registered report, I will also be looking at threat to control networks as well. And finally, I will test the exploratory mediation between PAH effects on irritability through brain connectivity. The goal of my Career Development Award is to gain skills in preschool irritability assessment, something that I hadn't been previously exposed to clinically. Neural network analyses and PAH exposure science. Those skills will then set me up for my future directions. So in the near term, I plan to continue to probe this model while collecting these data, as well as use data that is already extant to answer these questions and others, such as the interaction effects between chemical and social exposures on children's mental health outcomes, which we've previously published on in this cohort and others. In the long term, I plan to write grants that will allow me to explore alternative exposures, as well as follow these children into pre-adolescence when anxiety and depressive disorders are known to emerge. Finally, thank you all for hanging in and for your attention. I'd like to thank my funding sources, as well as my colleagues and mentors and the participants and families without whom we could not have done this work.